So the title is like a sentence from the patient. Like the patient was so like funny and always with high spirits. So I used his sentence to start the afternoon report, asking, "Am I pregnant?" With like funny smile on his face. Okay. So the chief complaint was increased abdominal girth. HBI, 63-year-old male with no significant past medical history, presenting with 6 months of gradually increased abdominal girth with diffuse abdominal discomfort and 2 weeks of low-grade fevers. Also reported poor appetite, worsening fatigue, and intermittent lower extremity cramps. With an intentional weight loss of around like 30 pounds over the past 6 to 8 months. In regard to review of symptoms, as I mentioned, he had unmeasured fevers, but without chills. He mentioned intermittent night sweating, poor appetite, and intentional weight loss, 30 pounds. And also mentioned worsening exertional dyspnea for the past six months. Without any cough or hemoptysis. He denied any chest pain or orthopnea, reported diffuse abdominal discomfort and tightness, especially for the past 2 weeks, intermittent nausea without vomiting, and also constipation with no signs of GI bleeding. Also mentioned that he'd been noticing like a little bit of darkening of his urine. Otherwise, no other issues. In regard to his past medical history, no significant like past diseases. He had appendectomy at age 22, no known allergies. In regard to family history, his father with high blood pressure and CVA, mother with Alzheimer's disease, and died at age of 75. Siblings and kids were healthy, and there was no family history of cancer. And he's not up to date with his cancer screening, never had colonoscopy, although it was CT chest. He's a smoker for like more than 20 years and quit 20 years ago. Never drink alcohol or never used any IV drugs or any kind of like drugs. He's a widower with 2 healthy sons and 1 daughter, and he lived with his daughter. History of remote incarceration, and he's Middle Eastern man, immigrated to the US 10 years ago. Actually, he's Syrian. His no recent travel, none in the past 5 years, no recent hospitalization or second contact. And for if you know, this is a case even before COVID. I met the patient when I was in Providence. And I like get involved in his case because of he's like Syrian and Arabic speaker. I was doing observership at Rhode Island Hospital at that time. So there was no COVID. Hopefully we'll get rid of it soon. And he was on no medication like or herbal supplementation, just like only multivitamins because his daughter was nagging on him.
So before we move on to physical exam, Nour, maybe we can ask, your co-residents what they would like to do. I don't know if anyone needs to ask any questions about his past medical history, review systems. This is the time to do more investigation here. If anything you like to add.
I think there's a lot of red flags in the history of this patient. The symptoms that he's coming with, the loss of weight, increase in abdominal girth, that's pointing more towards like malignancy versus like liver cirrhosis. Given his background, I would say what they call it, hepatitis and cirrhosis can be in the differential, but for sure malignancy is like on the top of my differential. But infectious etiology as well can be there. There's also smoking history that have been since the 20s. So I think around like, we can say 20 years of smoking. So there is a lot of risk factors.
Hmm.
Blood transfusion as well. I don't know,
No.
but for sure infectious etiologies have to be ruled out.
Thank you, Fatma. So that's absolutely correct. You have a broad differential at this point. That makes absolute sense. And before we go back to you, and I would like to ask you later on, what will your physical examination be oriented towards? And maybe 3 things that you'd like to do to examine this patient. I'm reading when Tej is asking, other than the transfusions, has this patient, had any tattoos in the past or previous episodes of jaundice or discoloration of the skin?
No jaundice before, no tattoos before. But on further questioning, he had a sexual assault while he was in prison.
Interesting. And this is the first time that he's experienced this increased abdominal girth as well, correct?
Yeah, for the past 6 months, it's been like gradually increasing.
As well as the other constitutional symptoms that he's been experiencing.
I mean, yeah, but most of them were more recent in the past few weeks, except for weight loss.
Okay, so that's something that's progressing. And then Athena wants to know if this patient has had any pale stools. I think you mentioned the urine with some discoloration, or is a darker looking urine.
Yeah, but the stool was the color was normal, but he had constipation, especially for the past few weeks, and oral intake.
Athena, what would it point towards if you have acolic stools?
I was thinking pancreatic malignancy, like obstruction.
Okay. Or maybe any changes in his bowel habits, steatorrhea, or did he have any of those symptoms, Nour?
No. No steatorrhea and no change in the color of his stool. It's not white.
Does anyone have any more questions regarding his past medical history or any other questions for his review of the system? Any other symptoms that you can think of?
Nour, do you know if he has any history of either positive PPD or known exposure to TB?
So when he came to the US, he did quantiferon, which was positive, and they did because he was asymptomatic, and they did chest X-ray, which was negative at that 10 years ago, before coming here. We don't usually do the skin test because we get vaccinated for TB, especially at his age, not like my generation in Syria. So
yeah, I was gonna ask if in Syria he must have gotten vaccinated, right?
Yeah, at his age, yeah, most likely. All my parents are vaccinated, but that's why we do quantiferon instead if we are screening for latent TB.
Which is something that you should know is also historically common in Latin American countries, and something to keep in mind. Mantasha is asking, did he have a medical checkup or any screening after that sexual assault in prison?
No, because of the stigmata, they don't even talk about it. But I ask him in private because I know what happened in prison. So yeah.
And is he sexually active? I know he's a widower, but sexually active otherwise?
No.
And David wants to know if he had any previous infections that he could recall.
No. He was totally healthy even after getting out of prison. He never, and he don't like to visit doctors in general, and his just because of her his daughter, she was nagging on him just to be examined, and his primary care just refer him to the hospital.
Just remind us, Nour, when was the incarceration, the time frame?
It was in his 30s for 20 years. Maybe 25-year-old. I'm not totally sure, but he was incarcerated for 20 years.
Nour, and you mentioned that this person maybe never felt sick. Is he someone that's up to date with vaccination?
I'm not sure about his vaccination before his 20s.
Okay.
But we don't do Hep B vaccination in Syria, for example, or Hep A, because all of us are like infected with Hep A. Any other questions? So,
I mean, I just find it interesting that he hasn't had a colonoscopy done. Even someone that, maybe his threshold is different for disease, but I think you mentioned he was already in his 60s and hasn't really followed up with a provider. So that's something to also keep in mind, perhaps.
Yeah.
So Fatima, if you would like to give me maybe 3, selected things that you would focus on in physical examination for someone that's coming with these symptoms, like you mentioned.
I would definitely look for stigmata of liver cirrhosis.
What would that look like?
For sure, first, by inspection, distention of the abdomen, any vessels on the skin, any hemangiomas. I will look for any jaundice that the patient didn't notice himself. Percussion to make sure that there is dullness, shifting dullness. I would look for flappy tremor. I would look for any lymphadenopathy, any enlarged liver, enlarged spleen. And for sure, for the lungs, I would look for any pleural effusion, any decreased air entry, any tremors in the hand. I think that's it mainly.
So spider angiomata, and you mentioned the shifting dullness and maybe fluid wave and other signs that we haven't mentioned of estrogen, dysregulations and cirrhosis. That makes absolute sense. And then you mentioned asterixis as well. Those signs may lead to maybe, a point towards liver disease. Okay. I'm going to share with you all, Nour moves on. And if anyone would like to add anything to that physical examination, I'm going to share an article that I found interesting that talks about the likelihood ratio for these findings and how sensitive they are in our patients. And that's something for us to review. But I would like Nour, because of the timing, if you'd like to go ahead with the physical exam.
Okay. So his physical exam, in regard to his vitals, he had a temperature of 38.4, which is 1.1 or 101.1, blood pressure 110/65, pulse in the 90s, respiratory around 17, and saturation 94 on room air. His weight is 64.6 BMI, 142.4 pounds, and his BMI 19.8. His general appearance was like elderly cathectic male with no acute distress. There was subtle icteric sclera. There wasn't any lymph nodes or GVD. And in regard to his chest exam, he had multiple 5 to 6 spiral angiomas in the upper part of his chest and back with decreased breath sounds in both faces with no crackles or wheezing. Heart exam was normal. Abdomen exam, it was tense, distended with diffuse tenderness. Positive fluid wave test with no capnoidosA. He has mild splenomegaly. Liver itch couldn't be appreciated, and normal bowel sounds. Extremity were warm and well perfused, and he had bilateral valvular erythema. No asterixis, and also grade 2 pitting bilateral lower extremity edema. Skin jaundice, but no rash. So like in general, he had like stigmata of chronic liver disease, beside diffuse tenderness, diffuse abdominal tenderness as well, and the fever. So anyone would summarize the patient. This is
James, do you think you'd be able to give us a one-liner or problem presentation for this case?
Sure. I mean, I'll just put it right in front of me, but 63-year-old male who has a 6-month history of increase in abdominal girth and associated with 30 pounds of weight loss, and on physical exam found to have stigmata of chronic liver disease.
okay. So yeah, as you mentioned, he's a middle-aged male with no significant past medical history or substance use, has remote history of incarceration, presenting with first episode of subacute progressive increased abdominal girth associated with fever, weight loss, and fatigue, and physical exam significant for stigmata of chronic liver disease and ascites. So like what would be in your differential for this patient? Like Fatma mentioned, cirrhosis, malignancy, infectious. So they are actually mainly the main things that we need to think about giving this patient. I will add to it non-cirrhotic portal hypertension, which might also cause some of the signs that the patient would have, heart failure as well with this volume overload, malignancy, and infections. What would you like to order for this patient as like initial workup?
I would definitely check a hepatitis panel on him, a right upper quadrant ultrasound, definitely a CBC, look at his platelet count also, a basic metabolic panel, check his electrolytes right now, his renal function. I would also check his urine because you said his urine was dark, just to see if there's blood, billy, whatever is in there. Would start there.
Okay.
And I would add, if we detect a good amount of ascites, to get some acidic fluid and send it to rule out SBP. But if we're suspecting for sure SBP, we have to like start him on treatment.
Yeah, exactly. So it would be like urgent as well, like CBC and blood cultures for this patient to send to do a paracentesis, because there is like concern for bacteria, spontaneous bacterial peritonitis, giving his like tenderness and fever. So this is the initial labs for him. He had like leukocytosis, normocytic anemia with no known baseline. His platelets 110. His creatinine was 1.4 with no known baseline. Oh, and I attach actually the like cost for some of these labs. His sodium was 133, potassium 3.6. His VBG unremarkable, lactate was normal. He has like mild elevation in his transaminase, ALT 60, AST 73. Total bilirubin was 4.2, diet was 3.9, alk-fast like 167, albumin 2.8, INR 1.4. His UA was negative for like infectious workup, and blood cultures were negative. So like just based on these labs, do you think he might have like cirrhosis or no? And like based on what you might like say yes or no? And beside the physical exam, would labs help you with like diagnosis of cirrhosis or no?
Yeah, he's losing some of the synthetic function of the liver, like looking at the platelets, the INR, the albumin, also low. Well, the INR slightly up, albumin slightly low, platelets slightly low.
Yeah.
Point towards possible.
Yeah, I mean, in regard when it comes to labs, there is like a score called Bonacini. Like it depends on, usually get points to how low is the platelets, the AST-LT ratio, and the INR. So like you can collect the points, and if it's like more than like like specific numbers, like there is like a whole chart, they will like be more likelihood to have a cirrhosis. But like at the end, it's like a combination of like clinical labs and imaging like that can help you with the diagnosis of cirrhosis. So this is his chest X-ray. It was done because of the fever concern like infection as a part of like an infectious workup, and also because he had like decreased breath sound in the bases. So basically he has like a little bit of like blunting in his right angle. But otherwise there is nothing else like remarkable. Next is ultrasound. So would anyone like to comment on the ultrasound imaging?
So it's definitely, the image on the left is definitely fluid around like ascites, you can see around the liver. Also like Morrison's pouch between the diaphragm and the liver. On the right, is that, not quite sure what I'm looking at here. Is that fluid around the kidney actually? So beneath the, is that beneath the spleen? Is that on the left-hand side?
Yeah, so there is like here the like fluid in the abdomen everywhere, and in this image you can see also has like the liver is a little bit shrinked, and it's like irregular boarding, and it's a little bit coarse. So these also like finding that might be compatible with cirrhosis as well. There's like fluids around the liver and fluids all over the like the abdomen, pelvis. So I just like before going up to the follow-ups, like we usually use like multiple scores to like after we have all clinical like stigmata of chronic liver disease labs that are remarkable to like low platelets, elevated AST-LT ratio, and low high INR, imaging compatible with cirrhosis as well. I mean, the definite diagnosis would be histology or fibroscan, but it wasn't done because it really was obvious that the patient has like cirrhosis. So we went like to calculate his child score or like MELD score, which are like two scores that can like help with the severity of like the disease and help like taking decision about management, and also to predict the prognosis of the patient. So the patient was like child C, which is like severely decompensated cirrhosis, and MELD was 23, MELD sodium 23, which is like more than 20, which is like really like with bad prognosis. But also don't keep in mind that the patient like most likely have decompensated maybe due to infection. So this is not like definite. We need to reassess the patient every day during admission or like on discharge, just like to predict his overall like prognosis after discharge. So this is the paracentesis. So the cell count was 1,500, differential 65% neutrophils. His SAG was 1.9, glucose 60, LDH to 290. His gram stain was positive for gram negative bacilli. Culture was positive for E. coli. And we sent like cytology twice. Which was negative. Each time was like more than 50 cc. So for cytology, it's like sensitivity would be 58 to 75%. And like whenever the amount of fluid sent is bigger, and like the frequency of sending, that would be increase the sensitivity as well. So based on these like results, do you think the patient has bacterial peritonitis or no?
Vintage, you're really quick to say yes. Do you mind sharing?
Why?
Sorry, yes. Yeah, I mean, I think the diagnosis is made when the neutrophil count in the ascites is more than 250, and 65% of like 1,560 is 700. And, I don't know, it's above 250. So I think it's diagnosed with SBP.
Yeah. Do you think we need to wait for like cultures to start treating the patient?
I don't think so. I think just the cell count is enough. I think the cultures will probably help later on down the line. But even if the cultures are still negative, I think you still have to treat the patient for SBP for 5 days and albumin, just based on the cell count alone.
Okay, and like you mentioned albumin, what do you know why we need to treat him with albumin?
I think it's volume resuscitation to kind of mitigate the risk of HRS, I think, in SBP.
Yeah.
I think a few reasons when albumin is actually proven to help mortality.
Yeah. So basically, like, so we treat with antibiotics for now, and like first day and third day with albumin, especially for patient who had like severe liver impairment or like kidney impairment, anyone with creatinine more than 1, BUN more than 30, and bilirubin more than 4. It's really better to treat them with albumin to just like decrease the risk of hepatorenal syndrome and mortality in general. So this patient was treated, and like his fever went away, and even his like liver function, kidney function were improving along his hospitalization. And we didn't repeat the paracentesis because he like clinically was improving. So we covered him for 5 days, and that's it. Just like a reminder for indication for paracentesis in general, anyone with new onset ascites should have one. Any patient hospitalized with ascites for the management of tense ascites or refractory to diuretics, and clinical deterioration of patient with cirrhosis, especially if he came with like fever, abdominal pain, tenderness, leukocytosis, hepatoencephalopathy, or alteration in his kidney function. Just like a quick reminder also for a patient with high or low gradient. Usually patient with cirrhosis would have a high gradient, like more than 1.1, along with alcoholic hepatitis, even if, massive hepatic metastases, heart failure, and usually the total bilirubin would be more than 2.5, pericarditis, urticaria, portal vein thrombosis, and idiopathic portal fibrosis. So basically here, like the main mechanism is the increase like pressure that can cause this, along with other vasoactive factors that can participate in this. It's like a transudate, if you come to think about it, in pleural effusion. And the SAG less than 1.1 is like similar to X-ray. There is like a pathology, like a typical or pathology going on in the peritoneum. Either it's like carcinomatosis or infections, pancreatitis, serositis, or like nephrotic syndrome. Like nephrotic syndrome is different because there is like decreased albumin in general. So there is like protein wasting. So it would be usually with less than 1.1. And here's like a quick reminder of like the pathogenesis in cirrhosis or non-cirrhotic portal hypertension. There is usually a combination between obstruction to portal flow and a lot of like alteration in vasoactive factors. And because of the low kidney perfusion, the defense mechanism would be activated to retain more sodium in water, and that would cause this the ascites. In regard to pathogenesis in malignancy, it's like also it might be carcinomatosis. It might be, actually, sometimes it might be high SAG because the mechanism would be massive metastasis in the liver, or lymph nodes that like just obstruct the flow in the portal vein, or it might be like lymphatic, like chylus, because of the lymph node like malignant invasion as well. But urticaria as well is like sometimes it accompanied malignancies as well. So here's the labs that you also asked for it. So it seemed that he had a hepatitis B. So his antigen service was positive. His total core antibodies were positive as well. C antibodies were negative, HIV negative, and we ordered the like the lipid bound A1C because like there is beside viral causes like a viral induced cirrhosis. There is like the NAFLD, which is also common, and we need to like figure out that there is like the patient has a risk factor for it, including diabetes or like lipid abnormalities, but they were normal. We also sent alpha fetoprotein which was 5.5, and just for the concern of like weight loss and in general like his constitutional symptoms, we sent some like tumor markers which were like unremarkable. So like, do you know, and like, what do you think the next step in regard to a Hep B for this patient? Is there any further workup that we need to order?
A fibro scan maybe to determine the degree of fibrosis?
I mean, at this point, he's cirrhotic already, right? I mean, giving his like clinical exam, labs and imaging. We might do it, but I'm not sure if it can give like a value for at this point.
I would say, sorry to interrupt you. Yeah, I would say hepatitis B viral load, hepatitis B antibodies, just to understand what is the stage of hepatitis B that he had, whether I think he's still having the surface antigen, so it means that he's still having the infection, and he have some LFTs abnormalities, but we want to know now whether to treat or not to treat.
Yeah, exactly. So the PCR was ordered and was like 28,000 units per ml. And we order as well HIV IgG was reactive. Any idea why we ordered the HIV? Would it like change the management in any way in general for cirrhotic patient with Hep B?
I think you gave the vaccine before. I think so.
Yeah, exactly. So if it's negative, I mean, you need to eliminate anything that might just like put the patient on edge again, like or cause decompensated, which is like hepatitis A. So you would give him the vaccine just to prevent such issues. So the patient in general was like treated with 5-day course of ceftriaxone and albumin in the first and third days. He underwent after that twice large volume paracentesis with albumin, with improvement in his clinical symptoms and renal and liver function as well. And the decision was made to discharge the patient to follow up with his PCP and his liver clinic in like 1 week to 10 days. So at this point, do you think like what medication do you want to discharge the patient on? And what would you recommend as an outpatient workup for him?
Or I see some answers in the chat. I can read them out loud. So Patrick's saying we can start spironolactone and furosemide. He's suggesting a 5-to-2 ratio.
What?
He's starting diuretics, spironolactone and furosemide in a 5-to-2 ratio.
Okay.
Wokar is saying can we treat SVP with ascites with antibiotics, diuretics simultaneously, or do we need to wait until the SVP is treated successfully and then start the diuretics? Let's say that there's no renal dysfunction at this point and he's back to his baseline creatinine. Mendy is suggesting that we need to discharge this patient with some sort of SVP prophylaxis, and I'm sure he's going to quote the reasons why he would suggest this.
Yeah, exactly. How about Hep B? Would we treat it or no? Would we start treatment?
I guess we don't know the answer, but probably
We'll
yes.
defer it for the GI people, but I would say, like you said, his liver function went back to normal in your follow-up. So I'm not sure how, or improved. I'm not sure what do you mean by improved.
Normal, but they are in 50s. His bilirubin, the last number was like 2.5. His creatinine went back to 1.
Okay.
Yeah, and his INR is still like 1.3.
So his LFTs went down to what?
He's
To what?
50s.
50.
Like, yeah,
Okay.
I remember the AST was 50, ALT was 45.
I think you would need, I don't know, GI specialist, but he will need starting treatment for each. But to discharge him with the treatment, I'm not sure, but he will need treatment for hepatitis B.
Okay.
The
Um,
antigen status,
well, I'm sorry, what?
like the HBE antigen status.
Yeah, that's a good point as well. So I will discuss this. So he was, as you mentioned, guys, he was discharged on low salt diet. He was also started on low dose diuretics on, like, as you mentioned, 5:2 ratio. We didn't start the others during hospitalization because he has like baseline renal dysfunction, and also he has like infection. Both of them can increase the risk of a bad renal syndrome, and we don't like to really start like diuretics during hospitalization. So he was hospitalized for about like 5-6 days, and we felt like he felt much better, and his creatinine went back to 1. So we started like small dose and to follow up in 1 week with the liver clinic. So that would be like a cautious decision. He was also started on lactulose for a goal of 2 to 3 bowel movement to just like prevent hepatoencephalopathy. He was also discharged on Bactrim for spontaneous bacterial peritonitis. Any patient who had like 1 or more episode of spontaneous bacterial peritonitis should be on prophylaxis forever. And he was started on tenofovir. There is a slide about this coming slides, and he needs to follow up with the liver clinic, and when he's like in better shape, he needs EGD for varicose screening and also colonoscopy for colon cancer screening. So this is the slide about the treatment. So whenever we want to like to take a decision about treatment a patient with Hep B, we need to differentiate between cirrhotic patient versus not cirrhotic patient. In cirrhotic patient, we don't care about the ALT or AST level or like the HBE antigen status. Actually, if the patient is in child A and he has PCR more than 2,000, we need to treat him indefinitely. And patient with decompensating liver disease, like cirrhosis with like B or C, we need to treat him in regardless, even for like the DNA, if it's like so treat if detectable, but in regard of the level. So we don't care about the ALT or the DNA level or the HBE antigen. And the cause why we treat is just like to decrease the risk of decompensating and to decrease the risk of HCC. So it's really beneficial to treat such patient, even if they are already cirrhotic. Like if it's not cirrhotic, it's a different story. We need the HBE status, we need the PCR level and the ALT-AST as well. So if the patient is positive HBE antigen and we have ALT more than 2 of the upper normal limits, PCR more than 20, we need to treat the patient at least 1 year after the seroconversion of E to like E antibodies. If it's HBE antigen negative, which we have due to mutation, so you need to treat if you have ALT more than 2 upper limits and PCR more than 2,000, or if we have like a histology of fibroscan, which like signs of like active inflammation or necrosis. So we need to treat these patients indefinite. But for cirrhotic patients, like for this patient, we need to treat him because he has a detectable DNA in regards to everything else. But we had the patient back to the hospital due to worsening fatigue, oral intake, fever, night sweats. Exam was like really, and like beside fever was like no changes. Like maybe his aside is a little bit like better than when he first admitted in the first time. We did like a whole like infectious workup that general, including blood culture, UA, urine cultures, chest X-ray were all negative. We repeated ascites flow cultures and were like negative as well. So at this point, what do you think? Why the patient is back with the, like the fevers and
Bactrim resistant is
no, I think we did that like paracentesis. His neutrophil is less than 250 and the cultures were negative. The SAG was more than 1.1. And the count were like more than 2 lymphocytes then.
Montage is convinced and has mentioned a couple of times that this patient may have hepatocellular carcinoma and maybe he would like to get an MRI. He's saying that, well, maybe the long-standing history of cirrhosis, the fact that he's lost some weight, which could happen in liver disease. And Waqar is saying, could this be a hepatoma?
I mean, like, so he had like ultrasound, like high quality ultrasound last time, and they didn't find anything. And you would like, it's really like after 1 month to have like a new liver mass, but it might be just like the one who did the ultrasound wasn't like that sure, but it's like I thought it's like it was high quality, but yeah, that might be possibility. Any other thoughts? Okay, I will go ahead. So we did like further workup. He had like elevated ESR, CRB, and like we also start like searching for like because his initial like infectious workup were negative. We like try to search for like another like infectious workup. So we did like procell antibodies were negative, like given like he was in the Middle East before, and it's like really common, even if it's like causing peritonitis is rare, but like we did, it was negative, and we did quantiferon was positive. We sent sputum acid fast smear, like on his sputum was negative, and to the TB cultures on the sputum was negative as well. We did a CT, chest, abdomen, and pelvis, and we found like this, a lot of like specific findings. And also in the abdomen, there was like a ascites with thickness of the peritoneum, like and some lymph nodes. So they're like the suspicious about like TB actually was like in the like first differential at this point, giving his giving the like this like opacities here and like the thickness of the peritoneum. So they went ahead and like they did another paracentesis, sent a special lab for TB. His ADA was 29. His the smear was negative. Microbacterial culture were negative. Because of the like his history, the quantiferon and the like the images, they went to do like laparoscopy and peritoneal biopsy, which ends up having positive PCR for Mycobacterium. So the patient was started on treatment for TB peritonitis for like the regimen was for 6 months, but I'm not sure if the patient had been able to continue the course. But yeah, he was started on this treatment. So for peritoneal TB, so it's like 6th most common site of extrapulmonary TB, account for like 4.9% of all causes of like extrapulmonary. It might be like a reactivation of foci in the peritoneum, which was like originally came from lungs, or it can be due to active pulmonary TB or miliary TB with hematogenous spread, or less likely it might be due to like a foci in the intestine or adjacent like organs like ovaries. In regard to risk factors, cirrhosis is one of the risk factors for TB, peritonitis, and also HIV, diabetes, underlying malignancy, malnutrition, and like immunosuppression treatment, including anti-tumor necrosis factors and steroids, and peritoneal dialysis. In regard to the workup, usually, I was actually surprised to know that the smear sensitivity is less than 2%. So it's like basically useless. The culture, 20%, but it can be increased to 83% if we said like 1 liter of ascites fluid. The ADA, this is the one of the take home points. The sensitivity is like 100% and specificity is 97%, but this is not for cirrhotic patient. Usually the sensitivity is lower, approximately like 30% in cirrhotic patient, which is like make it like really much like difficult to diagnose a cirrhotic patient with TB, especially also that the SAG in TB, usually it's less than 1.1, but if like for patient with cirrhosis, it will stay more than 1.1, even if they'd have TB peritonitis. So this is also another challenge. So the main thing to diagnose the peritoneal TB is to have a biopsy and then PCR on it, and with sensitivity 93%. The treatment is similar to pulmonary TB treatment, 2 months for the isoniazid, rifampin, ethambutol, and isoniazid, and then 4 months of isoniazid and rifampin for a total of 6 months, and there is no rule for steroids. But for this like special population, the cirrhotic patient, like, you know, like 3 of the TB treatment are so like like can cause hepatotoxicity, including isoniazid, which can like, and ethambutol, which can cause cellular injury, and rifampin, which can cause cholestatic injury. So we really need to keep an eye on this patient, and like with frequent LFTs, monitoring with cutoff to discontinue treatment if bilirubin more than 3 or the transaminase is more than 5 of our normal limits. But yeah, I'm not sure how like the patient is doing, but hopefully he's like, at least for the like the first few weeks that he was treating, like receiving treatment, he was doing well. But yeah, this is the case.
It's a very interesting case, Nour. Very, very interesting. But I'm like wondering, did we help this guy reactivate his TB by giving him tenofovir, which might be immunosuppressant? Did you consider switching from tenofovir to anything else after this reactivation of TB?
So I think it doesn't like his symptoms were way like far away from like even starting tenofovir, and I don't think like tenofovir can like cause reactivation of the TB. I think like his decompensated cirrhosis like was one of the reason of like his immune system was like awful, and he got like the reactivation of this TB. But I don't think like tenofovir would be the one of the causes of this now. Any other thoughts?
Wonderful presentation, Nour. I don't know the answer to that either. That'd be interesting to look at, and maybe we can ask Dr. Osorio and get back to you on that. But thank you. That's something that we don't frequently see here. I do think I had one case of suspected TB, but I know that there was no biopsy or anything else that we could confirm with. Any more questions? Oh, everyone's saying thank you. And thank you, Dr. Safar, for joining our
Of
afternoon.
course. I mean, it's entirely possible that this guy also had it when he came in with SBP and we were just not looking for it at the time.
Yeah.
So, I mean, we'll never know really, but it was a great presentation, Nour. I haven't seen you since you were an intern.
Thank you for joining.
Of course, I enjoyed that.
And thank you for all the teaching, Nour. This was fantastic. All right, guys. We'll see you soon then. Thank you for joining.